Well, welcome everybody. You might notice that your view is a little askew for the med list today,
Mhm.
but that was on purpose. I'm trying to be really tech savvy, Donna, and make it easier for those viewing on mobile to be able to
Yeah.
see bright shining faces. My face, not as nice to look at, but we have Kelly and Donna on today, which you
Mhm.
guys pay attention to them instead of me. So hopefully that'll work.
I don't know,
Pleasure.
Kevin, you're throwing off my game here with this change. I don't know.
Change is hard. But transitional change is even
Yes.
harder. And that's what we're going to be talking about today with Kelly. I think the transitional changes when we go to hospital, we were writing together just, what are we going to call the episode and how are we going to talk about it?
Yeah.
Transitioning into a hospital is hectic. It really is. Usually you're
Mhm.
making decisions on what's my coverage like? Where should I go? Who's going to take care of X, Y, and Z when I'm gone if it's a major event that's occurred. Then
Yeah.
you're in the hospital, you're getting no sleep, and the transition away from the hospital to home,
Yeah.
you're thinking, "Oh, Lord, just please get me home. Like, I just need to be there." And you realize that transition can be even worse for a lot of
Right.
people. So I'm really thankful we have folks like Kelly to be able to make it so much easier for our patients to transition successfully. I
Mhm.
talked about that in this episode. Any other components, Donna, you want to add on before I throw Kelly in the middle of us here?
Yeah, so we were just talking about this today in my group of students, and we were talking how important it is to even move while you're in the hospital, if you will, so that you can get home because we're all trying to get home and not necessarily, wanting to go to the short-term rehab or, wherever else transitioning. So trying to get you back home and what might you need to do. So I think we're going to be talking more about that going from hospital to that more ambulatory care setting. So back home and in going to your clinic for the follow-up. So I think that that's going to be an important factor that we'll
Oh,
be
huge,
talking about today.
huge.
Yeah.
Hey, Kel.
Hey there. Hi.
Hi, Kelly. So today we have with us Dr. Kelly Ulen. I hope I said that right. Is it
Yep.
Ulen? Is
Yeah,
that
you
right?
got it.
Okay.
Yep.
Because I know I pronounced it wrong the last time. So thank you, Kelly.
You're good.
And she is a clinical pharmacist in ambulatory care at Yale New Haven Health. Kelly is passionate advocate for improving senior care pharmacy and mentoring the next generation of pharmacists. And Kelly, I know that we've spent a lot of years in ASCP together and talking about our students as well. So it's amazing the work that you do. Her dedication to this field was further fueled from her personal experience with her mother, who was diagnosed with front temporal degeneration in 2019, and talk about transitions not only for your mom but also for you and your family. So I'm sure that there's been a lot to learn in that area. She's been on so many different boards. I'm not even going to name them all, and I'll let you talk a little bit more about yourself, Kelly, and some of the amazing things that you do. But one of the things is that she's part of the Senior Care Pharmacist Editorial Review Board, which is, I think, an important part too, because you're seeing so much of the information coming across in fresh new studies as well. So thank you for your work with that and all your work with students and with patients and caregivers.
Oh, thank you. Likewise.
Well, welcome and glad you're here. So please tell us more about you. Tell us about your journey to geriatrics and really this whole transitions of care that you're really steadfast in and doing such great work in.
Oh, thanks. Yeah. So my career in pharmacy started with a PGY1 residency at a VA, and I went into it thinking that I wanted to go into oncology after a high school sweetheart had cancer when I was in high school. And I quickly learned that I actually loved my weekend assignment as a resident where I would have to do medication reconciliations with the veterans. And they actually really wanted to learn about their medications. They wanted to learn about the side effects, and they had the time to focus on how the medications were impacting their bodies and whatnot. Whereas it seems like in general, to paint with broad strokes, but sometimes I think younger patients are so busy with our lives. And as a mom, I also totally understand that sometimes it can be hard to tune in and focus and see if you're having side effects that aren't overly obvious from a new medication. But anyway, so that spurred my interest in geriatrics. And then after residency, there was a geriatric emergency medicine pharmacist position that had opened where I was living in upstate New York. And so I took that position, and then I ended up with that institution for over a decade and was able to grow personally and professionally a lot there. So I certainly cherish my time having worked at Upstate and with all the wonderful colleagues that I recently left behind when I left there this past November. So my time there, I created the clinical pharmacist position in the emergency department for geriatrics, and we got JETA accreditation. And then about a year after that, created a transitions of care clinical pharmacist role on a transitions of care floor, which was within the hospital, but from a billing and regulation purposes was considered totally separate from the hospital and was a short-term rehab, so governed by CMS long-term care facility rules. And on average, the patients would be there for about 12 days. They could be there for up to 21 days. And that's where I really got to learn how to create protocols for pharmacists that allowed us to really, at least if not streamline therapies for the patients, at least empower them and educate them about their meds and start those titrations or, start optimizing their medication list, which was really a great opportunity for me professionally. And then I also discovered ASCP in that time as well, which has become my professional home. And then a couple of years after that, administration was going through our department and they said, you guys are doing a great job in geriatrics. You guys should be training the next generation of pharmacists, So we were fortunate enough that the executive director at the time found the funding, and I was able to create a PGY2 geriatric residency program, and that became ASHP accredited. And when I left in November, we were on our 8th resident. So that was a really exciting opportunity and probably my favorite impact that I got to make while I was in my time at Upstate. And also became an ASHP guest surveyor for PGY2 geriatric programs, which was really fun as well to kind of see behind the curtain for other programs of what they're doing well and to bring that back to my program. So, and then let's see here, after I've been at Upstate for about, I think it was 11 and a half years. At that point, I was senior management. And I was a residency program director for the program, but I was still working weekends and holidays, and I have young kids. I worked Christmas last year. So my husband and I had sat down when our oldest was in pre-K, and we were talking about, what do we want our life to look like personally and professionally a year from now? What are our financial goals? All those kind of things that we sit down and talk about on a regular basis. And we both decided we either wanted to be part-time or fully remote. So we put that out there. And a year later, my husband was able to go part-time. He's an engineer. So that was really nice. And that has been wonderful for our family. And I had gone to leadership at the time. And I said, hey, I'm interested in going part-time, which doesn't really exist in the state system. I mean, it's not allowed, but it's kind of a unicorn. And so after a year, I met with them again and I said, hey, where are we at? And, they needed another year to make it happen. So I had decided by that point, it was probably time to move on. And kind of a short little interesting side story of how things kind of work out, how they're meant to be. I had a resident who had graduated from our program a few years prior who was working for Yale New Haven. And she said, Kelly, the work-life benefit is really good. And so I applied to a position. And I wasn't even really sure that I was ready to leave at that point because I was, tenured senior pharmacist, right? And I really loved my role and what I was doing. And I wasn't looking for another job or looking to leave at that point. But I was like, well, the best way to learn about a new position is to apply and just hear about the day-to-day from the hiring manager. So I applied and I went through, I think it was like 5 rounds of interviews. And at one point you have to present a patient case to a panel and go through different things. So I felt kind of a lot like a resident again, right? It was very humbling. And fast forward, and I didn't get the position. And I was like, I think that was meant to be. Because at that point, even if I had been offered it, I don't know if I would have taken it because I really wasn't quite ready to leave yet. There was just so many projects that I was really passionate about that weren't done yet that I really wanted to see through. And then about 6 months later, when I was in a very different position, a lot of projects had been wrapped up, a lot of accreditations had been reissued. I was more open, I think, at that point in time. And so, Yale New Haven called me out of the blue and they offered me my pick between 2 positions, which was also very Yeah, because I think the first time when I didn't get it was a little humbling, right? I was like, okay, this wasn't meant to be, but I was also, a little, I don't know, to be honest, I guess I was a little surprised. But I was also okay with it. So then when I ended up, having my pick of 2 positions 6 months later, it was really nice. And that felt really good. So I chose to be a multi-specialty pharmacy and ambulatory care for them, which means I'll get credentialed in a couple of their clinics. And then I will, rotate between those 3 clinics. So far, I've only been with Yale now for about 2 months. So it's still very fresh, my experience in the ambulatory care world as a pharmacist. But I can say I love it. I work fully remote. So I got licensed in Connecticut, but I still live in New York. I didn't realize how much I would love working fully remote. I am an introvert and extrovert, so this is a great balance for me. My dogs have never been happier because they have.
That's wonderful.
It's also just incredible to get to work in an even larger institution than where I worked before.
Yeah.
So it's been really interesting to see just the depth of the bench at Yale New Haven and the credentials of my colleagues. A lot of clinicians I get to interface with are MD, PhDs, and they're authors on studies that are often cited in the guidelines. And to be able to just bounce ideas off of them of like, hey, this is going on with this patient. What are your thoughts? How would you like to proceed? Is just such an incredible opportunity professionally. So it's been really fun. And all the pharmacists are also incredibly kind and also very well credentialed. And so I really enjoyed the journey and the transition. And I have no regrets for leaving. And I really also love working Monday through Friday.
There you go. There's nothing wrong with that. Yeah. Especially if you put in your years, which I think many of us do. So that's wonderful. So I'd love to hear a little bit more about the whole transition of care, and just explain that a little bit more. And I think in all of your experience, of course, working on transitions of care, whether it's directly or indirectly. So can you share some of that with us and what you see are some of the successes and maybe some of the barriers to successful transitions of care?
Yeah, absolutely. I think the number one overarching theme for patients who successfully transitioned, whether it was inpatient or in the ambulatory care section, really is the ability to advocate for oneself, either advocating for yourself or having a strong care partner who can accompany you to appointments, have a clear understanding of what the plan is. Why are you taking the medication you're taking, right? Every patient should know, or, someone on their care team needs to know why they're taking this medication, when it's expected to start working, and when can they expect to be able to come off of it, right? I think we oftentimes, unfortunately, in the current health system, their providers are very rushed, as we all know. And so patients get put on medications and maybe another physician put the patient in. Donna, I understand this is very much your wheelhouse. So I know you're very familiar with this too, but patients get put on a medication by one doctor and then another physician doesn't want to take them off of it because it wasn't their medication that they started, but it's not appropriate for the patient anymore, especially as they're aging. So I think the patients who really do well understand what medications they're taking and carry an updated list with them, in your wallet, because you don't plan to go to the emergency room most of the time, right? But that's when we really need to know what you're taking so that we can either optimize your medications or, remove things that are inappropriate. I remember years ago in the ER, when I was an ER pharmacist, I saw a patient come in who was not a native English speaker and was on 2 DOACs, so 2 medications to thin the blood. And that was just really scary. Fortunately, he hadn't fallen, but it could have had a much worse outcome had that not been picked up pretty quickly. So, we certainly are having, and technology is improving, and, oftentimes some of our computer softwares are able to communicate, but not always, right? And now that I'm especially, working for an institution in a different state, I even see how some institutions don't communicate across state lines or throughout, cross systems. So that can be really challenging too, especially when a patient's like, well, it's in the computer, but that's not necessarily the correct updated list of what you're actually taking. So I think the biggest overarching theme is to know your medications and to be able to advocate for yourself. Don't feel bad to ask questions, right? It's your health. Ultimately, you are the one who needs to drive the success of of what's going to happen to you. So, I think just advocating for oneself is the best thing that you can do through all the different transitions of care. And then trying to avoid readmissions in the hospital, right, is another huge key piece. Patients need support after discharge. There may need to be more supports put in place. I've worked with incredible case managers and social workers who helped try to help to have that happen, so that we could reduce those readmissions. And then now working in the ambulatory side, I see how we're trying to prevent, especially like in the pulmonology clinic, right? We're trying to prevent patients from having exacerbations, not having to go to the ER, optimizing their medications, and just utilizing the support medications like prednisone on short basis just to get them through, but not have to go to the hospital. So, yeah.
If I could ask you just another quick question, I'm sure Kevin wants to jump in here, but just because you brought up that COPD, I know that even in the hospital, we're trying to de-escalate the corticosteroids, the inhaled corticosteroids, that especially if people have been in the hospital a number of times due to pneumonia. And we know that inhaled corticosteroids could increase the risk of pneumonia. And depending upon the patient and labs and some other things, it is appropriate to try to get that patient off of the ICS, the inhaled corticosteroid, and just be on two medicines, the LABA and LAMA, long-acting beta agonist and a long-acting muscarinic antagonist. So have you had success with that? I know it's a little touch and go trying to change that because it is newer in the guidelines. And have you had successes with that? And how is it being approached by those that are prescribing as well?
Yeah. So I know we follow the GINA guidelines pretty closely for asthma and whatnot, and the GOLD as well for the COPD. I do see a lot where they utilize, which I wasn't familiar with this in the hospital, but I see it now in the clinic, is where they're really utilizing Symbicort, not only on a regular basis, but just for PRN as well. And actually doing less with the SABAs. So that's something I think that is a bit different, but I see that a lot in the clinic. Yeah. So in terms of, I think there's more of an emphasis just from what little I'm seeing. And again, I've only been in this.
Exactly. I'm kind of
as well, to be fair. I've only been in there for a few weeks. So I'm still very much learning, and it's very different than it was inpatient, because inpatient, as you know, there's like the 3 inhalers that you have on formulary, and that's what you have to work with, right? Or else maybe the patient can bring in their own, but for the most part, you're using formulary. So it's a very different world now on the ambulatory care side, as well as also now introducing biologics. So, but I know there's a huge emphasis, though, on really trying to minimize the use of the systemic corticosteroids, for sure. I've seen in clinic, but I can't speak enough yet about the inhaled corticosteroids because I haven't been in the clinic long enough. So I can tell you in a few months.
Sorry to put you on the spot like that.
No, not at all. I'll be honest. I don't mind.
I do like that happened right there. I think for our conversation, like you had Kelly being put on the spot, answering a question that she wasn't exactly sure how to answer. And that's what transitional care is for every patient, right? There's the old saying of everybody has a plan until they get punched in the mouth. And I think that during transitional care, you get punched in the mouth over and over and over again as an individual patient. Kel, to be able to help out the audience from, not just your experience you're having now with doing some of these elements of care, transitions, but also as you were developing the programs, your previous role, where did you see a lot of the shortcomings? Where did you see elements where either one, the clinical team, not on purpose, but ended up failing the patient in one way, shape, or form, or the patient wasn't prepared enough to be able to answer or help with some of those questions so that transitions could go better?
Yeah, that's a great question. So I think to first answer it from the perspective of as a care team, I think the shortfalls happened when there was lack of communication, right? When everyone wasn't on the same page. And I found the greatest path to success, at least where I had come from, and I think it probably is applicable anywhere, is really you want to find a physician champion to help to spearhead that, whether it's the quality improvement project or whether it's a new protocol you're trying to put in place. the equivalent of that in the outpatient world would be a CDTM. So I think really finding physician champions is huge. And in order to make things new processes become successful, as well as really good communication prior to implementation, and then reassessing after it's been implemented to figure out, okay, so every year we're going to re-update this protocol because I was contacting the physician 10 times a week for this thing. Let's put this into the protocol. And constantly just, remaining open to ideas. I think for me, one of the greatest benefits I had was working with residents all the time, right? It's residents and learners, because they have fresh eyes. I love people who are curious and they want to know the why behind what are we, why do we do it this way? If the answer is it's the way it's always been done, then we need to look into that further, right? That's not a good answer. That's not a reason to continue to always do it the same way. And then from a patient perspective, when things weren't successful with transitions of care, it was typically, as I touched on earlier, but when patients don't know what medications they're taking, or they don't have somebody or they have a hard time articulating, or they're a poor historian, and then they don't have a care partner or anybody in their care team who can help them in the outpatient setting to kind of help to bridge that gap. And I think we're running into this a lot throughout our country. How do we keep people in their homes longer, and when they don't have a good support care team? And that's a really tricky question.
Walk me through this, Kel. Like some of the things that I've experienced through hospital components and transitional care and in various settings has been, one thing has always been true. If you want to discharge someone well, then you need to admit them well, right? The admission process is key to a good discharge. And so what does that mean?
Yeah.
A lot of times during admission, we are trying to do a med reconciliation of an individual and be able to pull out all these individual tangents of where drugs are being procured. And that doesn't always mean you're getting it from your one pharmacy. There can be multiple pharmacies, mail order, you're taking supplements, you're getting something from overseas, and pulling those into one list for the clinical team to be informed is extremely important. And I've struggled with that, over the years in multiple facilities, that can be a burden on the nursing staff, on the pharmacy technician crew that's doing it, on physicians, to be able to get that right. And then the other piece is at the back end where I see some major pain points. We talked about it in a committee, and really we're looking at discharge planning. Like, what does the discharge summary look like? How does that look to the clinical team? How is it being extracted from the electronic health record? And then how is it being translated for the individual patients? And oftentimes it was hey, here's a big stack of paperwork. I have not had time to look through it. Here it is for you. It may not have your right name inside of it. It may talk about conditions that you don't actually have. It's going to mention multiple drugs in all these weird ways that you think you're supposed to be on one, but you're not supposed to be on that one. That was just in the hospital. Now you're on this drug instead. And so those are the big pain points that I've seen. Is just really the admission didn't go well, and therefore it just didn't flow well overall. It's kind of like the garbage in, garbage out, right? Kind of thought process. Yeah. And then on the back end of things, we're really looking at discharge summarization tools. And that's a big push, today, to advance those in one way, shape, or form. And for any patients or clinicians that have worked with that, that those can be cumbersome at the very least. And so your thoughts, Kel, on those two things, on what you've seen work well on the admission side to do better for discharge, and to the discharge summary, how have you reinvented that to make more successful clinicians and patients?
Yeah. So I think the most successful and really an interesting unit that I got to work on was a transitional care unit. And it's where the pharmacist had been embedded since the unit's inception. So that was helpful to make sure we had a seat at the table and really were able to help improve patient care. But so what would happen is on admission, the pharmacist for that floor would actually go see that patient in person, or they would, call the care partner if the patient couldn't speak for themselves, or were a poor historian. And they would actually go over their medications, look at their immunizations, see what immunizations they needed to get. There was a QI project on that unit where we actually were able to order the 5 most common vaccines for older adults if they needed them.
Love it.
Yeah, then our vaccination improvement rate was incredible on that unit. They actually got a healthy aging designation for that QI project, in addition to all the other wonderful things that the staff did. But that was a big part of it as well. And then throughout their stay, right, doing education with the patient on their medications, or if we were making a change that we were hoping the patient was going to continue to implement beyond discharge, we found that the most success happened when the patient or their care partner understood why we were making that change. And that way, when they go to their primary care and they have 8 minutes to see their provider, they can really make sure to advocate for themselves of why they need to be off this PPI, or, why whatever change occurred should continue beyond outpatient. And then at discharge, a pharmacist would look at that after visit summary and go into the patient's room and go over it with the patient. And I can't tell you, even though a pharmacist was involved in every touch point along the patient's care from beginning to end, how many of the after visit summaries still didn't look correct, right? So it still was showing things that shouldn't have been on that med list. And then, reporting that to your IT department to try to upgrade the behind the scenes working so that it can be improved for going forward. So that was definitely, I think, one of our most successful units. And it was very alarming, though, that even on that floor where we were so embedded in the patient's care, that there was still that many problems identified. It was like, imagine all these other patients where, you don't have that amount of time. This was a one pharmacist to 20 patient unit, right? It's a very rare ratio inpatient. We were very fortunate to be able to do that. It's certainly not that ratio on other floors. And so how do we, catch all these things still on other floors? And that's where I think that utilizing AI within the software is going to be key to identify. They're utilizing, scoring systems and that kind of thing to try to help to identify these issues so that we can improve and really go after these high-risk patients to make sure that they really understand what's happening. I was reading today an article from Yale New Haven Health where they're trialing having a telehealth nurse actually do the admission and discharge remotely via like an iPad in the patient's room to free up the floor nurses who are doing med pass and whatnot. And how successful that really has been, because, these nurses who are remote can actually spend up to an hour with the patient doing this admission or this discharge. So I thought that's a really creative way that I haven't seen yet done to try to also really help to empower that patient to understand the changes that have occurred and how we can try to keep them out of the hospital going forward.
Yeah. Love that model.
Yeah. I thought that was pretty creative.
So Kelly, you mentioned it, and I see this too, is that, you make some changes at the hospital, right? And you're doing it in really hopes that this is what the patient's going to leave on. And like you're saying, whether it be software or something else that is going on, or change in, who's discharging as to who the doctor was, the hospitalist during that time of the hospitalization, for the most part, making a lot of those changes. But how I know we don't have the crystal ball here, but were there any successes at all in regards to how that could be switched a little bit better to make it a smoother transition for folks? So if something really was stopped or something really was reduced, it really reflected in that transition. Or do you think like some things are even just handwritten, just not necessarily changed in the, I kind of wonder that, because if someone's going over it, I can just see someone going, no, this is really what it is, kind of thing.
Yeah.
So I'm just curious, what are your thoughts on that?
I think some of the more successful patients who we wouldn't see back again and, within the month, were the ones who on their after visit summary were taking notes, right? They were making a notation about furosemide to, last for 6 hours, take it earlier in the day, that kind of thing. So the patients who were really invested in the success of their health going forward and understanding why these changes were being made, or they had a daughter who was doing a great job taking notes as we were doing the discharge counseling. So I think from the healthcare standpoint, I think we need to do a better job at providing after visit summaries that are actually accurate. And even little things, right? Like maybe the outpatient takes Lantus, inpatient, outpatient Basaglar probably is what they're taking. Inpatient, the formulary is changed to Lantus, making sure we're not discharging them on Lantus because they already have Basaglar at home. They don't need 2 long actings. That's actually setting us up for, potential med error, right? So I think we need to make sure we improve after visit summaries, and then that patients really have a good understanding of what the plan is going forward. So that, again, I feel like my word for today is going to be advocate, but you got to be able to advocate for yourself. Having seen it even professionally and personally, right? Like my mom with dementia or my father-in-law had ALS. You have to have somebody on your care team that's going to advocate for you, because you just don't have a lot of face time sometimes with the providers who are trying to do their best. So,
Oh, go ahead, Jonna.
No, you go, Kevin.
I was just going to ask for the advocating piece, Kel. I'm really curious on this particular point that you were making there. You mentioned one particular drug, furosemide, which is a diuretic or a water pill, often used in congestive heart failure to be able to keep a fluid load down for those individuals that are struggling with edema, et cetera, at home, for all the folks kind of following along. With that, you notice that Kelly did mention it lasts for so long and not to take it later in the day. That's a beautiful thing. That is a very pharmacist related component of how do you take care of your patients beyond here's your drug list, right?
Yeah.
How do you feel, Kelly, that those aspects, because I truly feel like those are the hidden gems in healthcare. Why people are successful and why they aren't is not because they know their drugs, like just the names of them. It's because they know how they work and how they work for them, right? They monitor them, et cetera. How you mentioned AI and technology. How do you feel that some of those aspects of care, right, especially during transitional care, can be implemented into someone's regimen, so to speak, into their knowledge base, instead of just knowing, I know I'm on these 5 drugs and I've got to take them at these times? How do we add all of the other aspects that are so important to personalizing their care?
Yeah. I mean, I've seen on a really good after visit summary where they have common side effects are listed with the medication so that the patient can be empowered to know what to look out for. So I think that could be pre-populated in a relatively easy fashion, utilizing our technology that already exists. I think another piece is, how long until this should I expect, to see this working, right? So dermatology is one of the clinics I have just finished up my training in, and so I'm credentialed in that one. Oftentimes, a lot of those medications, it's going to take 6 months before you're going to see a result, even though you're doing an injection every 2 weeks, right? So I think it's really important. I feel like it's my responsibility as a pharmacist prescribing this medication for the patient is expectation management. When should you expect to see results? What's a fair amount of time to have trialed this before we rule whether or not this is a good medication for you? I think understanding common side effects, how to store the medications, all of these things I think could also be populated on that after visit summary that could be helpful for a patient just for expectation management purposes. I think of 6 months as a really long runway, especially if you're having really itchy, flaring in your skin, and it's incredibly uncomfortable, right? And you're doing these injections every 2 weeks. Like after that first injection, I want it to work, right? So I think these are steps that we, is an incredible, a good area that we could be pre-populating on the paperwork, as well as having a conversation and a dialogue with the patient about, and figuring out what matters most to them, right? And then how do we select the correct therapy for them based on what's most important to them? If it's being able to walk to the mailbox or walk their dog, or being able to play with their grandkids, right? Like all of that needs to be a part of the care plan and be considered as we're choosing these therapies for the patients to make sure that we're going to optimize, healthy aging for anybody.
I love that. Yeah, I think that Don already knows that I'm part of the Joshua Newmiller fan club for sure. And gentleman with the ADA that's a WSU grad did the same residency that I did, Kelly. But just the other day, there was a paper that was put out, Don and Kelly, not sure if you ran across it, but it was in deprescribing in diabetes. And so with diabetes deprescribing, the one thing that was really fascinating is they put kind of a layered breakdown of here's what the issue is that the individual is having, here's what the next steps are going to be, and the contingency plans. And I think what you mentioned there, when it comes to 6 months worth of waiting time for something to work, well, what do I do between, right? I mean, if my option is, well, I guess I'm going to go back to the ER, because that's all I know what to do, then that's where we really leave our individual patients. So I think having that stepwise algorithmic process that we all think of in medicine, applying that to patient care and allowing them to have their own algorithms that we're supporting them with is a really great kind of add-in for you there that makes a lot of sense. Back to you, Donna.
Yeah. So I kind of wanted just to talk a little bit about the statistics of transitions of care, if you will, and what results. So what's our big concern? So transitions of care, of course, going from hospital to home, hospital to rehab to home, wherever it might be. And what are some of those issues? And And so why is this such a big deal for transitions of care? And I know, being part of Falls Prevention Coalition in Massachusetts, that's a big deal, right? We know that older adults have an increased risk of falling when they're in these transitions of care. And I was reading some staggering statistics just about falls in long-term care. So say someone's going from hospital to long-term care, for example. And it's not necessarily just that transition, but long-term care in general, 50 to 75% of people fall in long-term care every year. Like, that's amazing to me. And so thinking about those transitions, thinking, the help that these folks need, for one thing, to gain strength and to be strong. And so thinking about that, even going home, like, so what's happening? Well, people are in the hospital. They've probably atrophied their muscles somewhat because they've been lying in bed. And I just think it's really important that people move when they're in the hospital, that they're not just lying in bed. When you're lying in bed, pump your feet and, lift your knees up if you can, and do some marches while you're sitting in your side bed chair. So I think those things are just really important. But then you have the medicines and just not feeling well. Like, you don't feel great when you're leaving a hospital necessarily, no matter where you're going. So having that weakness, if you will, or if you had a procedure, like, something's not going to feel quite right anymore for a little while you're trying to heal. So there's still a lot of readmissions that happen. And I read this is like 17% of readmissions. And that's just in general, that's just average. But we know certain disease states actually increase that as well, that percentage. So, what are some of the stats you might have come across, or what are some of the things in place that you might have seen or done in your different roles to help reduce those poor outcomes of transitions of care? Why we think this topic is so important?
Yeah, that's a great question. So first, I'll tell you some statistics I've come across from pharmacist-led things. Then I'll tell you about a multidisciplinary group that was created at my previous institution and how that was successful. But I think, to talk about elderly patients, right? So pharmacist-led intervention for elderly patients discharged from the emergency department reduced unplanned hospital readmissions within 28 days. So that, that 1 month benchmark, from 22% to 10%. So that's an incredible reduction, right? And then near and dear to both of our hearts, Donna, our impact on high-risk patients. So pharmacists conducted comprehensive medication reviews for high-risk patients, reduced 30-day readmission rates from 20% to 12%, with an absolute risk reduction of 7%. So we know that if we're able to embed pharmacists in these patients' healthcare, we can reduce readmissions, we can reduce poor outcomes through these transitions of care. And then, from a multidisciplinary perspective, which I think is always the path to success, especially working in geriatrics, I think we are privileged to always have multidisciplinary teams in general and understand the importance of that. But they identified high risk for readmission patients, and these were predominantly patients with mental health issues at the institution I worked at previously. And they actually put together a team that was spearheaded by case management, but also consisted of pharmacists, providers, social workers, and they would actually, meet, talk about the patients, and then they would have outreach to the patients to remind them about their upcoming appointments after discharge. And if they needed it, they would even facilitate transportation to these appointments to ensure that they got to them. And they were able to reduce the readmission rate. I don't know the exact statistic off the top of my head, but I know it was quite drastic and it was incredibly impactful for the community. So it would be nice if, models like that could be replicated other places. I think sometimes patients, everybody, you need, if you don't have a care team, whether it's family or friends, we have to find a way to be supporting individuals in the community that don't have a care team to help keep them out of the hospital, because the ED cannot be the catch-all that it currently is. That's just not optimal care for our patients. So we have to be able to keep patients in their homes or out in the community, but with supports in place to get them to their appointments, right? To help make these appointments if the patient can't make them for themselves. Yeah. So those are 2 ways I've seen it be successful.
That's great.
Wow.
That's wonderful. I always like to say to people too that always be talking about your meds no matter which appointment you go to. Yeah. And that, like you're saying, this multidisciplinary approach, it's so important. So even if you're going to PT, is your balance off? Are you not motivated? Are you just exhausted that you're just not moving well, kind of thing? And what could be causing that? Is there medicine perhaps? And then, no matter where you go, dentist, dry mouth, or other swallowing issues or things like that, that's all, manifests down the road to not being able to nourish yourself well, and then causing more problems. So I always like to think about it and educate not only the patients, but also the multidisciplinary groups too. So that everyone's educated about, there could be an issue with meds and in patients here, and then all of these transitions too. So I think it is so important. And I'm so glad you mentioned that multidisciplinary side.
Yeah, I think with the multidisciplinary commentary there, Kelly, I'm really curious on your thoughts here. Let's say we do it perfect, right? Let's say that we get all the meds right? We get them home. They got all the exact medications we wanted them on, and they're making all of their trips to their appointments, right? Their clinical appointments. Talk to us a little bit more about the social determinants of health aspects and some of the lifestyle components that we feel like we already have some solutions that folks might not know about that you can kind of help educate them on, or 2, where some missing gaps might be. And what do I mean by that? Sometimes we get the med list perfect, but the perfect med list is no med list. And so when we get them home, and to be able to do that, we say at discharge, well, make sure you're exercising and eating right. Well, what does that mean to anybody? Nothing is what that means, right? That means I'm going to go back to status quo on how I was living and operating previously. So what are we doing right now when it comes to transitioning folks to healthy meals and helping them with exercise regimens appropriately so that they can leverage their treatments that are in place, their medications that are in place, and actually get healthier with better outcomes, not just be adherent to drugs?
Yeah, that's a good point. I mean, when you mention exercise, it brings to mind, especially in older adults, programs like Silver Sneakers at the YMCA, right? We know that one of the greatest indicators of healthy aging is going to be a strong community for a patient, right? I read a study a while ago now that was comparing not having a community or, supports for older adults is very similar to having been like a cigarette smoker, multiple pack per day. So it's crucial that we, either have a community or we develop community. So that's one way I think if a patient's able to exercise, to develop that community at a local gym or through Silver Sneakers or one of the senior programs for exercise classes at the senior centers. I think those are excellent ways to also help hold each other accountable with an exercise buddy to make sure that they actually get there. Yeah. If insurance will cover it, or if a patient can afford it, meeting with a nutritionist, I think, is one of the best ways, or at least keeping a log of their meals is one of the best things they can do. When I was pregnant with my second, I had gestational diabetes. So that was a really eye-opening experience, right? It's one thing to counsel these patients on their meds for diabetes and about blood sugar regulation and the importance of protein and, protein to carb ratio, that kind of stuff. But to actually have walked the walk for 9 months, it just gave me a whole new appreciation for patients who live with diabetes every day. And it's just constantly on your mind of where's my blood sugar at? And I was fortunate enough to be able to utilize a continuous glucose monitor so I could make sure I was in range 99% of the time. But this is before, insurance would cover that. So even being able to have access to one of those, right, was a privilege. So importance of exercise, importance of making sure you're eating well, there's lots of apps out there now too. I utilized one of the apps when I was pregnant, just logging every single thing I was eating to make sure I was getting the right amount of fiber and protein. And we know as we get older, we need to make sure that we're getting enough protein and fiber, which is often in the American diet not inadequate amounts. You actually have to actively work to try to make sure that you're getting enough of it in a day, and it's just into drinking water. So I think those are some of the things, having a really strong sense of community is probably the number one thing I think that can be helpful, because also I've seen situations where it's not a daughter or even a family member, but maybe a church member who becomes a person's, helps them to advocate for themselves at appointments. One of my mentors, his wife ended up, she was a great advocate for her mom. And once her mom passed, a neighbor down the road was like, hey, you did such a great job with your mom. Can you come to my appointment with me? And she was very kind, and she was able to make it work with her life and in her schedule. But, you never know where you're going to find your support, but it's really important that patients do identify support people in their life. So I think those are just a few of the things that come to mind that aren't medication related. They're going to help with healthy aging and, keeping people in their homes.
I have to say, I had an interesting conversation the other day with a care manager. So in the community, and in how they're able to work with the patient and the caregivers of the family caregivers to really navigate what was available, and then also to provide what wasn't happening for the patient. I think that that's really important, especially when we're talking about transitions of care too, when you're just kind of like, where am I at and what am I going to do? Especially if it's a new diagnosis or something new, you now have to, kind of work a different schedule around some medicine or some injection or whatever it might be. And I think care managers in the community, and I don't know if a lot of people like really know much about giving a care manager a call so they can actually navigate this for you, and then they fill in the actual gaps of care that are necessary for that family, for that individual.
I've not heard that title before, so that's good to know. It sounds similar to nurse navigator. I'm familiar with a nurse navigator that will help patients navigate, orthopedic surgeries or oncology diagnoses and the subsequent treatments. But that's good to know that that's another resource in the community. Do you know, Donna, are those predominantly private pay, or are those typically covered by insurance?
I believe that they are more private pay, which of course doesn't necessarily help with social determinants of health. But there could be some of what is covered. I know, like, each area has like their elder services groups, and they're able to figure out what you're eligible for. You might have so many hours of care per week that you were allowed in the home, and then they can work that out for you. So that's more of the elder services that might be in someone's area that would be covered. And then there's also a lot of these other programs like PACE programs, or there's also there's the PACE programs, and then there's the I know that it's a little bit different, the adult daycare, which can be PACE, but not necessarily PACE, that people might have hours covered for.
Yep. We looked into that. I found for my mom, when we first started navigating her dementia diagnosis, the Office of Aging was really helpful. They actually had access to a few grants that they were able to then offer for my mom to be able to go to the adult daycare. I remember I was researching daycare for both my son, who had just been born, as well as my mom. And I was like, man, talk about the cycle of life, right? Like daycare for both.
Right.
Yeah.
And talking about transitions of care for all of you. My goodness. That's amazing. You're all moved to different parts.
It was a trialing time.
That program awareness is an interesting one, to bring up right there, of just sharing what's currently available, what is billable. All of those aspects are something that most patients really care less about, right? Until it really, really matters to them, and then they don't know about it. So some things that are developing right now within CMS, there's CHWs, or community health workers, that are starting to be expanded. How they're being billed and paid for is pretty substantial. Home health organizations and healthcare access networks, all of those things are currently available throughout communities. But the one thing, Kelly, that I'm really curious when it comes to transitional care, I know some institutions will leverage a social worker, right, or a community health worker in some way, shape, or form during that transition to talk to the individuals about different placement opportunities, right? So where are you going to go after you go home? Do you have a place at home that is safe for you? Can you be able to recover and be successful in rehab? Looking at all the basically qualifications necessary, the good old 2 midnights rule and everything else that's out there for them to have transitional care to a rehab facility. But why I see that is this: I feel like without someone going over your benefits with you, I don't know if anyone has received a benefits package anytime soon. And if you're out there and you're listening and you read through it, I mean, kudos, right? I just threw mine away just the other day and hope there's a PDF that I can search through to be able to take care of that. But with those benefits, a lot of times there's things like food is medicine. For a lot of individuals that are looking to say, I don't know how to cook for myself. I need to be able to transition to something healthier. There's food is medicine programs. Dawn and I had a great guest on the other day to talk about that. And then with the exercise programs that are available, a number of Medicare, components that will pay for you to go and exercise in one way, shape, or form in a facility. And so I'm curious, have you seen that integration of someone doing a benefits analysis for someone at transitions of care to go, not only here's the care plan from the hospital, but also here's the resources in the community that we want you to be aware of?
I think the closest that I've seen to a successful model of that was probably case management at the hospital prior to discharge. They were, coordinating patients or patients' family with the financial aid office to help them if they needed to apply for, Medicaid, for example, or Medicare, to get some service, to access the services. And they were also making sure that it was a safe discharge. We would have interdisciplinary rounds twice a week where we would all sit around the table. So it was physical therapy, occupational therapy, nursing, providers, pharmacy, and case management. And it was led by the MDS nurse. And we were actually, talking about, is this a safe discharge? What are their social determinants? What kind of support system do they have? And I think from me sitting in those rounds all the time is part of why when I bought a house, I bought a ranch, right? I saw how many people couldn't go home because they had 10 stairs to get up to their upstairs, one bathroom in their house. So just things like that. Or, could the patient afford, or is there a grant in the community that we can put a chairlift in their house, right? So they can get up to that second floor bathroom. So things like that. But that's the only successful model I've seen. And that was from more of an inpatient perspective. I don't know about in terms of outpatient what exists. I saw at the geriatric ambulatory care clinic where the social workers were really helpful with coordinating with the care partners to ensure that they had what they needed, and trying to address caregiver burnout as well, which was really huge, especially in the older adult population, for the care partner. But I think there's probably, just off the top of my head, it feels like there's a really big need for more of, what you're talking about, because I can't think of an ideal model that I've currently seen that exists yet.
I think senior centers are a good place to start. Because every community does have a senior center or council on aging. And I think that they're a good starting place because they probably know what's available in the community and are probably able to, if they can't help directly, they would have the connections or maybe even some of the transportation available. So I do think it's a really great idea to always check with your senior centers too. If you are stuck and not quite certain where to go, I think that they would be very good at helping you navigate to some services. Kevin, in regards to your benefits package information, I get calls on that all the time from family members. Can you help me figure this out? It is a constant stream that I get. So some people do figure it out. No, they just ask someone, right?
But hold the family member.
And then, and I think all these things that you're talking about in regards to social workers and caregiver burnout, those things are also important too. So, and I think what's important for people to know too is if you're uncomfortable, say you're the caregiver and you're uncomfortable, someone's coming home right from the hospital, and what am I supposed to do? I don't know if I can do this, whether it's care for a wound or change something that somebody needs, or inject something, or feeding tubes, whatever it might be. You might be somewhat educated, but there's so many questions around that. So make certain that you get the support that you need, and that you're asking all your questions and making certain you're comfortable, because that's even a transition for those folks, for those caregivers having to do those new functions, if you will.
And I saw many times in the hospital where oftentimes discharges, at least in the short-term care realm, were dictated by insurance coverage. And so they would say this patient's cut as of Tuesday, but the patient could, patients were educated and given a form that they could refuse their discharge. And then it could go before an appeal board to be taken up with their insurance, where they would reevaluate, all the notes from the patient's stay. But that's within a patient's right to say, I don't feel safe going home, or a family member can say, I don't feel safe changing this feeding tube, or, you're not changing it, but, feeding the patient through the feeding tube. And so sometimes that's where they would also do like in-home nursing visits, and that kind of stuff could be set up for those patients.
Yeah, totally. I guess last question for me, Kelly, is this: what are you the most excited about that you're kind of seeing coming along the way in transitional care management? That you're seeing new things, maybe old things being reevaluated and done differently. What are you the most excited about seeing in the near future?
Yeah, I'm excited about the implementation of AI done in a safe way. I think that we can, free up provider time in an appropriate way. I know I've seen it trialed where I currently am, where, somebody couldn't attend a meeting, but instead they had, like an AI bot essentially go for them and took notes and then summarized the meeting afterwards. And I've seen in the software that we currently utilize, which is the Epic software, where a patient will send you a message through the patient portal and it'll actually draft a response that then I can go through to make sure it's appropriate and to edit however I see fit. But it is time saving to utilize AI just in those, little ways. So I'm excited about, as our technology improves, it's really exciting to see cross states, even a patient's immunization history, right? Being able to just pull from different databases in different states to see if they are up to date or not. So I think with the proper implementation of advancing technology, I think is really exciting. I love seeing how well pharmacists are utilized in the current health system that I'm working in an ambulatory care setting, and how often they're expanding their FTEs for pharmacists in that capacity, and how much they value a pharmacist working at the top of their license. That's really rewarding and also incredibly beneficial for the patient as you're developing these relationships with them. Encourage patients to, whatever it's called in their system, but like it's My Chart and the system I currently work in, utilize a My Chart account. It's a great way to have access to your provider without having to go in for another visit. Things that could be addressed that don't require you to go in person. If your insurance and whatnot will cover, I think telehealth is a great opportunity, right? Especially for starting a new medication. I can meet with a patient and we can go over, as they're doing their first injection of a medication, how to do it and to make sure that they're comfortable. And I'm right there with them on the screen, right? So I think that as we evolve and technology continues to improve and be implemented in healthcare, I think it's going to be a good thing.
Love it.
Thanks, Kelly.
Yeah, thank you, guys. It's always a pleasure to get to chat with you.
Yes. Yeah, no, fantastic and enlightening kind of conversation, Kelly. I love the transitions in your career, kind of the overall broad experience. I did not pay Kelly to say AI and software solutions
You did that
about at all, but I really like to talk to Kelly more about that. The other things that I think are just really critical for the audience to be able to understand from some of the things Kelly's talked about is not everything is perfect. Like even when we've created incredible programs, still we have things that kind of fall through the cracks. And as Kelly has kind of cemented, advocacy is her word. Really you have to be able to champion yourself or your family members to be able to do well in these kinds of situations. And as Donna said several times, don't be scared to ask more questions, right? I mean, or reach out to other resources that are in the area, which is so helpful. From the clinician side, Donna, any big takeaways you'd like to make sure the audience has before we close?
Yeah, I think it's important just to help the patients navigate, just give them ideas and make certain that they're comfortable with wherever they're transitioning to. And whether it be taking that extra minute to look at medications just to make certain that they really are appropriate, or jotting a note to be, this needs to be evaluated at follow-up after. And I just think that if we can all try to reduce the readmissions rate. If we can all try to make a little difference by just taking that extra minute to make certain that the patient really understands how they're going to be using a new medicine or what this change might be for them. I think that's a really important step that we can all take. And no matter what discipline we're in healthcare, I think just taking those few extra moments with patients and helping them, we might all be able to reduce readmissions, reduce the risk of falls for folks.
I love it. Well, thank you again, Kelly, for your time. Really, really enjoyed it. Thank you, audience, for your attendance and for all the little notes that I'm seeing on the side over here. Remember to follow us on Facebook, LinkedIn, and YouTube for all the latest and greatest from the MedList. And we'll talk to you guys next time. Bye-bye.
Thanks so much, everyone.